Hello, good evening, doctors. Today we'll be studying endocrine pharmacology. Please comment if I am audible and visible. Please comment if I am audible and visible. Hello. So today we'll begin with endocrine pharmacology, and after completing that, we'll start we'll start cardiovascular system. And the most important endocrine pharmacology and the most important geriatric disease that we have been facing regularly in our clinical practice is diabetes mellitus. We have already known how to diagnose and what are the different types of diabetes mellitus. And so, regarding the treatment, all the patients with diabetes mellitus need education on diet, exercise, and blood glucose monitoring and complication management. We need the lifestyle changes also along with pharmacology. It is a multi-drug, multi-specialty treatment. It's not only the drugs, but patient need about the diet, exercise, blood glucose monitoring, as well as knowledge about complication and complication management. Depends on type of diabetes and glycemic control. Are monitoring fasting blood glucose 2 hours pp, and as we had said earlier, HbA1c. So regular monitoring is required. And in type 1 diabetes mellitus, as we know, it is due to complete deficiency of insulin. So insulin needs to be replaced. Whereas in type 2 diabetes mellitus, it is due to insulin insensitivity, and thus initially insulin is not required. Oral agents are given, especially metformin is the first line. We can see that metformin 500 mg is most commonly prescribed drug, and also some non-insulin injectables not in clinical practice, but insulin replacement might be required on later stages when only oral drugs is not sufficient, and weight loss particularly help for lowering the blood glucose. And also another type of gestational diabetes mellitus, it will come in uh, gynae part also, and this is in gestational we need to do insulin replacement. So we will try with nutritional therapy, exercise, and if it fails and OGTT shows hyperglycemia, then we will go with insulin replacement. And another question is, what is the insulin that is given in IV form? Okay, this has been question that has been asked previously, and it is regular insulin. It has been asked on 2079, 2079 CE exam, and it is regular insulin. Just remember, regular insulin. It is the only IV insulin. Other insulin are given in form of subcutaneous. We'll see the types of insulin and their duration of action in a chart just below. And also, it is the treatment of choice for DKA. We had seen already about the DKA and hyperkalemia. As we give in hyperkalemia, we give IV insulin with glucose as in the form of infusion, and also in case of stress hyperglycemia. So now there is a picture. You need to learn about this picture. It's very helpful in understanding the mechanism of action. First is increasing insulin sensitivity, and we know that insulin increase in adipose tissue and skeletal muscle. GLUT4 is the receptor, that is insulin dependent receptor. So whenever we give these drugs, biguanides, that is metformin and thiazolidinediones, these drugs will increase insulin sensitivity by increasing this receptor in adipose tissue and skeletal muscle, and in this way they will help in decreasing blood glucose level, and also they will decrease glucose production from liver, that is decrease gluconeogenesis. The other is SGLT2 inhibitor. We had already said there are two kidneys, so SGLT2 is present in kidney, and it will help in, it will do what is, it will inhibit the glucose reabsorption. We know 100% of glucose is reabsorbed from PCT, but if the blood glucose level has crossed the renal threshold, then it will be present in urine and it will prevent the reabsorption. That means it will decrease blood glucose. And also other is alpha glucosidase inhibitors like acarbose that will decrease glucose absorption from intestine. So the mechanism is increase insulin sensitivity, decrease glucose production, decrease glucose reabsorption, and decrease glucose absorption. Similarly, there are some glucagon-like peptide analogs, GLP-1 analogs, DPP-4 inhibitors, MI analogs. These are all that help in counter regulatory mechanism. That is, they will act on pancreas. Okay, and here it is like glin, glip, glyph. These all act on pancreas. These were not acting on pancreas directly, whereas these will act on pancreas directly. And we know glucagon does the work of increasing glucose, so they will decrease glucagon release and they will decrease gastric emptying, whereas sulfonylurea, meglitinide, and also GPL analogs and these inhibitors will also do increase insulin secretion by pancreatic beta cells. There is a chart just below. We'll go through the chart, and you can just print out this picture or keep it as a screen in your mobile, so that whenever you can frequently visualize this. And in the chart below we can see that, so we'll go from here, the most common drugs, and I'll just highlight the most important part or most important common questions that have been asked. You can go through all the chart and try to remember if you can. So we know we biguanides, metformin. One question that has been asked is, what is the investigation that you need to do in a patient before giving the or prescribing metformin? That is, we need to do renal function test, because if the patient has renal insufficiency, then it will cause lactic acidosis. This is very important. Also, vitamin B12, which vitamin deficiency is caused, is vitamin B12. That is why a patient with diabetes might have already neuropathy, and in addition to metformin, we are giving metformin and it will cause vitamin B12 deficiency, and overall there might be uh, paresthesia and neural problems, and we need to prescribe them multivitamins or pregabalins. This is a detailed mechanism. We had already seen hepatic gluconeogenesis is inhibited, and peripheral glucose uptake is increase in insulin sensitivity. And main enzyme they are acting is this glycerol 3 phosphate dehydrogenase. which is an enzyme of hepatic gluconeogenesis. And the other is thiazolidinediones, that is GLIT, T for T. Okay. And among these, 5-glitazone is commonly used. And one question is which has increased cardiac risk? That is pioglitazone. It has increased risk of heart failure, edema, and also increased risk of fractures. Okay. So, rosiglitazone. This was the exact question. Increased risk of MI, cardiovascular death is rosiglitazone. So just remember, Rosi is rose related with heart. So this group of antidiabetic drugs are damaging or they are harmful to heart. And this is a mechanism. PPAR4 is a nuclear receptor. Overall, it increases insulin sensitivity. The other part is increasing insulin secretion. This was increasing insulin sensitivity. This is increasing insulin secretion. The first generation sulfonylurea, they are obsolete nowadays. They are not used because of disulfiram like reaction. We know that whenever a patient is taking taking disulfiram or other disulfiram like drugs, takes alcohol, then the patient will suffer from nausea, vomiting, restlessness, and all this will cause a reaction that will uh, that will prevent them from taking alcohol. And this is also used in de-addiction. The other is second generation of sulfonylurea, glipizide, glyburide used commonly. And the main mechanism is they will close potassium channel in pancreatic beta cell. We had seen in the picture before in the mechanism of release of insulin where potassium was the channel which enters inside the cell. Sorry, when glucose enters inside the cell and potassium channels are closed, will create a potential over here and which will again open the calcium channels, and in this way there will be exocytosis. We had seen this in insulin physiology in how insulin release is dependent on glucose, and this has also whenever there is increase in insulin secretion, that means there will be increase in risk of glycemia, that is hypoglycemia, increased risk in renal insufficiency and weight gain. Other part is similar. We had said that there will be increased glucose-induced insulin secretion, like we have seen that GLP-1 analogs, liraglutide. This will decrease glucagon release and increase glucose-dependent insulin release, similar to above, but this is dependent on glucose, and also it will act on glucagon. So these are all just mechanism and that we need to remember. Other commonly used drugs is sitagliptin. Okay, this is DPP4 inhibitor. So we have no way than memorizing this. Just the name, the mechanism, typical mechanism, if you can remember, it will inhibit DPP4 enzyme, and this will decrease glucagon. It is increasing insulin release, and this is also weight neutral. Similarly, decreasing glucose absorption from two sides. One is from intestine, the other is from kidney. So this SGLT2 inhibitors like glyphs. Just remember gliflozin. Remember FLO means flow. So this will cause glucosuria. This is important question. This was asked in 2079 that the among following the drugs causes UTI. So flow means urine flow. So we'll remember about urinary flow, and along with urine, increase in urine flow, there will be increase in sugar flow, and that will cause sugar. There will be bacteria, and it will cause fungal UTI and vulvovaginal calcium, and also it will cause dehydration, hypotension, weight loss overall due to dehydration. So it should be used in caution with renal insufficiency. This is a very important complication, and we know it will block the reabsorption of glucose in PCT. The other is alpha glucosides inhibitor, that is acarbose. Just remember this. So this will inhibit the intestinal brush border enzymes glucosides. We know that these are the enzymes that will secrete that will form disaccharides to saccharides, and this will be decrease carbohydrate hydrolysis and decrease. So this is important. Whenever a patient has postprandial hyperglycemia, we see that the patient has very PP. So then we can prescribe acarbose, and it will cause bloating. And other, this is not common, but still amylin analogs, that is pramlintide, it is used for decreasing glucagon, decreasing gastric empty time, hypoglycemia. So we have seen this. You need to go through this chart at least 2 to 3 times. You need to remember that picture, and along with the picture, you can add up your complications and adverse effect, so that this will be you can memorize it easily. There are few important adverse effects like disulfiram-like reaction, glucosuria, hypoglycemia with secretagogues, and the other drugs that is used is type 1 is that also is insulin. Insulin is not natural hormone, and there has been a lot of insulin preparations, and we just need to remember the names. Rapid acting, that is 1 hour peak. We can see here that this is in hours, and this is the insulin level. So after giving it, rapid is usually given IV. So after giving it, the peak hour is, it can peak in within 1 hour. Okay, and uh, so remember lag. Lag usually rapid means no. So Lispro, Aspart, Glulicin. These are rapidly acting. These are IV given drugs. Then other drugs are usually given subcutaneous, short acting, 2 to 3 hours. The name is regular insulin. See here, regular insulin. Intermediate acting, 4 to 10 hour peak, NPH, nutraprotype. I mean something, there is the difficult name. And long acting is, it will act like over 24 hours, 18 hours. So there is no real peak, Detamere and Glargine. Okay, and the basic mechanism is it will act as insulin, that is by tyrosine kinase activity, and it will increase liver, to increase glucose storage in muscle, increase glycogen fat, increase TZ cell uptake. Overall, it will do the same mechanism that the normal insulin or our endogenous insulin is doing. And the side effect is hypoglycemia. Patient with insulin needs to know about the symptoms of hypoglycemia, like sweating. Sometimes patient may become unconscious. They should recognize the symptoms and take treatment. We have seen that they can be given sweets immediately, or if unconscious, they need dextrose. And also lipodystrophy, because this is given always, insulin is always IV or um, subcutaneous. So it is given in thigh, stomach, so it can cause lipodystrophy. Some hypersensitivity reaction. So this is all about endocrine drugs. We have few drugs that are hormones. So these are, we need to remember basic, the propyl thyracid, also known as PTU, and methimazole. They, the basic mechanism is, we had seen in the picture of pathology, in physiology also, the thyroid peroxidase, that is the enzyme related for oxidation, organification, coupling. So this will all inhibit, and overall there will be inhibition of thyroid hormone synthesis. Also PTU, P for peripheral, it will inhibit the peripheral conversion of T4 to T3. We know that T4 is required to be converted to T3 by blocking 5-dehydrogenase enzyme. And important is hyperthyroid. This is important question. This was asked in the CEE. The patient of 3 months, gynae patient, pregnant patient, all symptoms of hyperthyroidism was given, and drug of choice was asked. So PTU is the drug of choice. because methimazole is teratogenous. But if given on second or third trimester, then we can also go with methimazole. Methimazole PT has hepatotoxicity, and homeopathy we need to give glucocorticoids. In methimazole, what is the teratogenicity is aplasia cutis. You can just Google the picture of aplasia cutis. It is a dermatological disorder, and that's why we don't give methimazole in first trimester because most of the development occurs during that. And the adverse effects are skin rash. Somewhere other question was what is the investigation that needs to be done with methimazole, and it is CBC. That is because it might cause granulocytosis, aplastic anemia. Also, there might be hepatotoxicity and also vasculitis. This is for hyperthyroidism, whereas for hypothyroidism we give levothyroxine or liothyronine, that is T4 or T3, because we need to replace T4 or T3 in hypothyroidism in mixed edema. Nowadays it has been being misused for weight loss also. So that's it. So among this hypothalamic drugs, important is demiocycline. We are using it for SIDS, desmopressin for central diabetes, and von Willebrand disease. This was a very common question for this exam. Growth hormone we know for growth hormone deficiency, and oxytocin we know for induction of labor, and somatostatin for esophageal varices was the question on 2080. Or octreotide, acromegaly, carcinoid syndrome, gastrinoma, gluconoma, any tumor. Somatostatin is a hormone that will act as a regulatory hormone. So, any pituitary hormone excess will be controlled with somatostatin. And fluorocortisone is just a synthetic analog of aldosterone. That is, we will give it to retain fluid in case of primary adrenal insufficiency, also known as Addison's disease. And there might be some or heart failure, hyperpigmentation conditions along with it. So this is not important. In cancer, we can just see that on a patient with CKD who have hemodialysis, because there is a chance of hypercalcemia. We had already said that there is a chance of hypercalcemia with CKD patient due to secondary hyperparathyroidism. In that case, we are given zinc acid. This is not important. And in cation exchange resins, that is, these are also used sometimes for hyperkalemia because they will bind potassium in colon. Oral given drugs for mild hyperkalemia, we can use cation exchange resins. These are just the drugs, the common drugs. So we have completed endocrine pharmacology. I hope you could get a good overview from this. Next, we'll start the cardiovascular pharmacology, cardiovascular with anatomy. Thank you for being with me. I'll meet you in next slide. Good night.